Welcome to the lecture of urolithiasis, and we'll be discussing about the basics of urinary system stone disease now. See, urinary system disease is one of the oldest disease affecting the mankind, and the most commonly it affects the kidney, upper part of the urinary system. If you see the prevalence, it is around 1 to 20% throughout the world, depending on the geographical condition, climate, the dietary factor, and all the genetic factors. And if you see the incidence nowadays, the stone disease is increasing worldwide. The size may vary from very small, few millimeter, sand-like stone, up to very large, multiple branching stag on stone. Size varies. Okay, and the most common symptoms or presentation of a patient with urinary tract stone disease is pain, and which is usually associated with hematuria. Okay, which is usually associated with hematuria. Let us talk about some etiology or predisposing factor of stone disease. Basically, it is a multifactorial disease where a lot of factors come into play. Okay, uh, if you see, the male has a higher chance of getting stone disease than female, about 2 to 3 times higher. But nowadays, the incidence of you know, increased male incidence is narrowing. That is, females are also having more stone disease nowadays. If you see the race and ethnicity, it is more common among the white population, 4 to 5 times, followed by Hispanic and Asian Africans. Okay. This difference in the race may be due to genetic makeup as well as the dietary habit that we have. The Western diet has a higher tendency of making stone due to more fatty, more protein diet, as well as diet making a person obese. Okay, that's why it's more common along the white population. Obviously, the geography of climate, the hot and dry climate, is more responsible for the stone formation because it lead to it lead to dehydration, and dehydration lead to supersaturation of urine, and which lead to stone formation. Obesity is one of the problem, okay, nowadays in the world, and this obesity is also a risk factor for stone disease. Whenever the BMI is more than 30 kilogram per meter square, then the risk increases. And those who have the higher BMI, they have increased excretion of oxalate, uric acid, and phosphate in urine, leading to higher chance of formation of oxalic acid, uric acid, and phosphate stones in urine. As I have already told you, dehydration has a very directly role in stone formation. It leads to supersaturation of urine. There are some urinary disease. Okay, basically any disease that causes a stasis. Stasis means decrease in flow of urine. That can lead to stone formation. And suppose, for example, there is a so this is the kidney. Okay, the kidney. You can see over there. Suppose there is a obstruction of urinary flow due to narrowing at PUJ, just allowing little urine to go down, but more the urine will stay here in the pelvic calcial system, and this lead to the stasis, and stasis lead to supersaturation of urine and can start precipitation of a stone. So any obstructive uropathy, basically the bladder outer obstruction or a urinary flow like PUJ or VUJ obstruction, these can cause the stone formation more common. If you see, one of the most common cause of the bladder outer obstruction is BPH in old age. So in the case of BPH, it may lead to decreased urinary flow, and that decreased urinary flow may lead to stasis, that is, post-void residue of urine. And from here, it can lead to the stone formation as well. So see, any obstructive uropathy, obstruction in the urinary flow, can lead to stone formation. Similarly, the UTI. Okay, UTI is very important in stone formation. Basically, whenever there is infection of the urine by a urea splitting bacteria like protease, what they do is they break the urea, they split the urea into ammonium compound. Okay? The urea is split into ammonium compound by bacteria, that is mainly protease. Okay, the protease, that is urea splitting bacteria. The bacterial enzyme urease break the urea into ammonium compound such that the pH of urine will be increased, and whenever the pH is more than 7.2, then it leads to stone crystallization, and that stone is struvite stone, also known as magnesium ammonium phosphate stone. So UTI has a direct role in formation of stone because it alter the pH of urine. Okay. Similarly, one more thing I have to say you that the UTI can cause stone, and the vice versa is also true. The stone can cause UTI as well. That's why the urine culture is very important, because I've already told you the UTI may cause stone, so we can identify the proteus or other urea splitting bacteria, and you can manage accordingly. Or the stone disease can be associated with UTI. So these things are very important. Okay. See, those patients who have a we had a history of stone can have stone in future as well. So you can see over here, around 35 to 75% of patient will develop stone in 10 years. Okay, that is, it is very recurrent disease, because maybe the factor that is associated with the stone formation is still there. Okay, it is not removed. That's why. And that's why after the surgery of stone or stone removal, the most common, the most important point is we must focus on prevention of stone. So how to prevent a stone? There are some general guidelines. There are some specific guidelines. Okay, I'll explain later on. So this is very important. We don't want the patient to suffer by stone disease multiple times. Systemic disease, the the diabetes. Okay, the patient who are diabetic, they are especially type 2 diabetes. This patient have a higher chance of hypercalciuria, that is they excrete more calcium into the urine, as well as the pH become more acidic, which lead to the formation of some specific stone like calcium stones. Okay. Vitamin A deficiency. If you remember our basic physiology, then we know that vitamin A is essential for maintenance of the epithelium of the entire body, not only the immune system. And we know the epithelium of the immune system is known as urothelium. Okay. Whenever there is a lack of vitamin A in the body, then it lead to desquamation. Desquamation means the epithelial cell fall down, they are desquamated, and they can act as nidus. Nidus means one point of attachment where the crystals like calcium, oxalate, urate, phosphate, they get attached around this nidus and can form stone. That's why the vitamin A deficiency lead to desquamation of epithelium, mainly urothelium, and then acts as nidus, which helps to attract other crystals and may lead to the stone formation. This is very commonly found in the children. And if you see, the another cause is hyperparathyroidism. Okay, hyperparathyroidism means excess release of parathyroid hormone. And if you know that the normal function of parathyroid hormone is to increase the calcium level in the blood by absorption from the bone. So whenever there is excess secretion of the parathyroid hormone by the parathyroid gland, maybe due to adenoma, then it lead to excessive calcium formation as well as excretion into the urine, and it lead to hypercalciuria, as well as it causes increased excretion of phosphate in the urine, leading to the calcium phosphate stone more commonly in the urine. Okay, so and whenever there is a recurrence of stone disease in any patient, especially calcium containing stones, then we always check for the hyperparathyroidism. Okay, because this is one of the cause of recurrence of stone. See, there are some metabolic situation, okay, where it lead to the stone formation. Okay. See this first and second, hypercalcemia and hypercalciuria, they are very closely related. Hypercalcemia means excess calcium in the blood. Hypercalciuria means excessive calcium in the urine. Okay, so these conditions can be caused by either increased absorption of calcium from GIT, or due to hyperparathyroidism, where there is an increased calcium excretion and phosphate excretion in the urine, as well as there may be some condition where the calcium which should be reabsorbed by kidney is not reabsorbed and lead to hypercalciuria. So in all of these three cases, it lead to excessive calcium inside the urine, and that lead to crystallization of calcium along with other ions, forming calcium stones. Hyperoxaluria. Hyperoxaluria means excessive oxalic acid in the urine. Okay, basically it can be due to primary or genetic defect of metabolism, or maybe secondary cause. The primary cause is more common than secondary cause, and in secondary cause it is usually associated with the diet. Diet means some food contains more oxalic acid, like spinach, tea, chocolate, all those things contains more oxalate. Okay, and whoever it in excess of these things can lead to hyperoxaluria. And also excessive vitamin C intake can also lead to conversion of these into the oxalic acid and lead to hyperoxaluria. That's why excessive calcium consumption is not advocated. As well as if the patient, if any person restrict severe restriction of calcium in their diet, then the restriction of calcium promote the oxalic acid urine formation, so hyperoxaluria, leading to oxalic stone formation. That's why excessive restriction of calcium is also not advocated. It may lead to oxalic stone formation. Okay. Hyperuricosuriia means excessive uric acid inside the urine, and the uric acid is basically metabolites of purines or protein metabolites. So this hyperuricosuriia may be due to the genetic defect, okay, like in the case of gout, or it may be due to the excessive consumption of the animal protein. So, or maybe some disease condition where there is excessive turnover of the cell, leading to excessive breakdown of nucleic acid and lead to the uric acid formation. In any of situation, whenever there is an excess uric acid formation inside the urine, it may lead to the crystallization of uric acid and lead to uric acid stone. Okay, and this stone must need acidic pH less than 5.5 to make a crystal of stone, okay, stone formation. Cystinuria is a genetic abnormality where it's purely genetic abnormality. It's not common disease, okay, wherever there's an excess of cysteine in the urine. See, in all situations, you have seen the excess in urine. But one situation here, it is that hypo means less. Okay, so hypositraturia is a condition where there is a lack of citrate in urine. Okay, see, the citrate is a natural inhibitor of a stone formation. Basically, it decreases in the formation of calcium oxalate and the phosphate and urate stones. So whenever there is a lack of citrate in urine, and that may lead to the stone formation. Basically, mainly oxalate, phosphate, and urate stones are more commonly found in hypositraturia. So these knowledge of a metabolic cause can be utilized later on during our prevention part. Okay, so I'll again revise this thing later on in prevention part, how to use this knowledge later on. So now what we can conclude is there are various factors which play a role to make a stone, and not all the factors are present at once in each and every patient. Some patient might be just obese, and the BMI, excessive weight or obesity may be the cause. Wherever, sometime in other patient, that might be just they're working outside in a very hot and dry climate, not drinking adequate water, and that might be causing stone formation. Whereas in some patient, there might be a anatomical abnormality like obstruction in the urinary tract, or maybe some might have metabolic disorders. So there may be a combination of multiple cause, or there may be a cause in different patients. That's why we have to treat each and every individual stone disease in different way. So basically, treatment means first we remove the stone, then the real treatment start, that is prevention. That's why for these all things we need to know about the etiology or predisposing factor. Now let us discuss about the pathogenesis. Okay, I'll be just discussing in very brief. Okay, see, uh, the stone, the basic mechanism of stone formation is the urine must be supersaturated. Supersaturated means the urine contains water and the electrolytes. Okay, a lot of electrolytes inside the urine, and whenever the concentration of electrolytes are more than the concentration of water, that means the water inside the urine is unable to dissolve the electrolytes, then the precipitation of the electrolyte starts. Okay, this is just I can explain by a very common example that we have learned in our school life. That is, suppose it is a glass of water. Okay, if you start adding the salt in this water, then initially the salt will dissolve. Okay, the salt will dissolve, and you will keep on adding the salt. Okay, fine. Against it will dissolve, but there will be a point of time when you if you add a little of the salt, then the salt doesn't dissolve, it start to precipitate. That point is known as supersaturation. So whenever you add an excess of solute or electrolyte or salt beyond the capability of the solute to dissolve it, then it will start to precipitate. That's why whenever the liquid gets supersaturated, the solute start to precipitate. And the same thing happen in urinary tract as well. Whenever there's an excess of electrolytes or a stone forming agent, then the water that is usually making it soluble, then stone start to form. Plus these process needs some additional help. Okay, for example, in our urine we have a delicate balance of a stone forming agent. Okay, stone forming agent which are always trying to form the stone, like the electrolytes like calcium, phosphate, oxalate, urate, all those things, as well as we have the agent in our urine naturally found, which always try to prevent the stone formation. These are known as inhibitors like citrate, magnesium, and pyrophosphate. There's always a balance between these two. And as well as we have a lot of urine or water that always want to dissolve the solute. So solutes that want to make a stone, the inhibitors that want to prevent the stone, and the water that always want to dissolve the electrolytes. So there's a delicate balance between these three components which always prevent the stone formation. But whenever this balance is disturbed, either by excess of electrolyte, like increased calcium level in the urine or oxalate level in the urine due to any cause, in that scenario, or in the same time, there might be condition where when the inhibitors may be decreased, like citrate is decreased, okay, or whenever this water part, that is there's a lack of water in the urine, that is due to dehydration, okay, dehydration. So in any scenario, whenever this delicate balance is is altered, then it lead to the stone formation, okay. So let's see. So we have three factors basically: the supersaturation of urine, then precipitation, then lack of inhibitors. So I've already explained everything. Let us see in the flow chart. Okay. See over here, the excess of stone forming substance like calcium and oxalate. These, whenever there's an excess of these things, then it leads to supersaturation of the liquid. Okay. And whenever there's supersaturation of liquid, added by the factor, the lack of electrolyte, sometimes the lack of inhibitors, or maybe sometimes the dehydration also. Dehydration, these all lead to formation of the crystal. Once there's a supersaturated urine, it starts to crystallize. Okay, it starts to form the stone. And once that starting of the crystal formed, known as nucleus, then the other stone, that is the other part, other crystal tries to form around it. Okay, trying to form around it. That means there's a aggregation of crystals around the nucleus, and they grow in size slowly and slowly and slowly. They grow in size. Okay, so this is the basic mechanism. Let me explain one more thing. You may say then the stones are very small at the beginning, so every time the urine is flowing, okay, so why not the small stone 1 or 2 millimeter that is formed at the beginning? Why not it is flushed out? Yes, it is possible. That's why there's a theory that there must be a anchoring site. Okay, so you can see the picture at the top right, that is a internal picture of the calyx of the kidney. You can see this yellow spot over there. Actually are these are the atherosclerotic plaque, that means fatty plaque, found at the vasa recta, or the vessels of the papilla. These fatty spots, which are the atherosclerotic or the fatty spot inside the vessels of the papilla, vasa recta, allow the anchoring point for these small crystals. So these small crystals get attached to these atherosclerotic plaque, also known as Randall's plaque, and which allows the crystals, the nucleus, the beginning point. It allows this crystal to get attached for a while, and later on, the remaining other crystals forms the stone around the nucleus. So this is the theory that this Randall's plaque inside the papilla, it helps to form the stone. So this is stone formation in summary. Okay, I hope you guys understand. Composition of stone. Basically, stone is formed of two things, that is stone crystals and matrix. Okay, the crystals means is the most commonly it contains crystals. Matrix is the sum around 2 to 10% of the stone volume contains the protein glycoproteins. Okay, and around that it forms the stone. Okay, mainly the crystals that is formed around these, the crystals are found. Okay, so basically around 90 to 98% of the volume of the stone is made up of crystals, and around 2 to 10% is made up of proteins, protein material. And crystal means it contains the same calcium, oxalate, phosphate, all those things. You can see over there, crystals. Okay, so this is the basics. Let us study about the types of stone. This is important. Types are always important for the management point of view. That's why classifications are always important. Remember these things. We can classify stone in various ways. The stone can be classified according to composition. That means the crystals, type of crystals, according to the plain X-ray characteristics, according to etiology, and according to the stone location. Okay, these are the common way to classify. So let me finish the last one first. Okay, location. So why we need to know the stone location? We can just say kidney stone, we can just say ureteric stone, we can say bladder stone. That's enough, but not enough, because whenever you diagnose the stone, we always want to manage it. Okay, so let me give an example. Suppose there's a stone inside the kidney, inside the kidney. Okay, and that stone is suppose uh, at the calyx of the kidney. Okay, so suppose this we're drawing over that is the kidney. Okay, so it is over here, like here. It is found over here. Okay, so see, this stone is lying locating at the lower calyx. So what's the importance of knowing the exact site of this stone? So if you know the exact site of stone, suppose the stone size is around uh, 2.5 or 3 centimeter, a large stone, suppose. And in that scenario, what we can do is, now, in the large stone, which is around more than 2 centimeter, occupying the lower calyx, for this patient, our approach would be PCNL, that is puncturing the lower calyx, going inside, breaking the stone, and bringing it out. PCNL. I'll discuss this thing later on in detail. Suppose the same thing here. The stone is there, and the stone is not big. Okay, suppose it is hardly 1 centimeter stone, and lying at the lower calyx here, suppose. Okay, and this stone now, being a small stone lying at the lower calyx, what we can now plan is, we can do the ESWL, that is, we can apply the shockwave from the external point, and we can damage break the stone, and just bring it out. Or we can go through the ureter, and we can break the stone by a laser known as RIRS. So see, the location is important. Okay? Similarly, let's give an example of a ureteric stone. Okay, you can see over here. So this is the ureter here. Ureter. We divide the ureter into three part: upper, mid, and lower part radiologically. So suppose a patient has a stone at the upper ureter, okay, over here. Okay, and another patient has a stone in the lower ureter. Okay, so the approach for these two patients will be different, right? So see, for the patient who have a stone in the lower ureter, the best option would be going from the below and breaking the stone and take it out. That is URS, ureteroscopy, right? Where we go inside the ureter, break the stone, and bring it out. But as the stone is upside here, the options would be different. Okay, we can use the shockwave ESWL from outside to break the stone, or we can we can just go from the below, and we can break the stone by URS, or we can push it back inside the kidney, and we can break it by PCNN or ESWL. So see, the location of stone give us idea how to manage it. That's why location is always important. Okay. Now let us discuss the other classification, the composition. Okay. So see, according to composition of, of a of a matrix, that is, sorry, of a crystal, we can divide the stone into basically two types, that is uh, calcium containing stone and non-calcium stone. Most of the stones are calcium containing stone, around 80 to 85, some say around 75 plus, doesn't matter. uh, the stone Most of the stones are calcium containing stones, and among that, the most common stone is calcium oxalate stone. Okay, and see, in the non-calcium stones, we have all the other stones that are not made up of calcium. That is uric acid stone, magnesium ammonium phosphate, also known as struvite, cysteine and xanthine stones. These are genetic stones, and drug stones like silicate indinavir and these drugs. So these are the example of a calcium and non-calcium. Is it important to know this differentiation? Yes, because the calcium stone behaves in one way, and non-calcium stones behave in other way, and the causes are also different. That's why it is better to know the calcium and non-calcium stones in this way as well. Let's see some examples of calcium stone, or this composition. The calcium oxalate stone is one of the most common stones, and these stones have very sharp edges. The sharp surface. The surface is not smooth. Okay? It is spiky oxalic acid, sharp surfaces, and this is good for the patient because once the stone moves, it causes hematuria. And whenever there's a pain and hematuria both at once, then patient will not stay at home and they will just come to the doctor. And that's why these stones are diagnosed in very early stage, so that it prevents the renal damage. And sometimes the stone is covered by the very clot due to excessive hemorrhage. It can be seen like this as well. And see, the more important one is All the calcium stones are radiopaque stones. That means you can see these stones in plain X-ray KUV. And the stone is important, is struvite stone. The struvite stone means basically it is composed of magnesium ammonium phosphate. Magnesium ammonium phosphate is known as struvite stone. And if the struvite stone contain additional calcium, that is calcium, magnesium, ammonium phosphate, also known as triple phosphate. So don't get confused. Whenever the magnesium, ammonium, and phosphate stone, that is struvite stone, has additional calcium, then it is known as triple phosphate. These are very, the surface are very smooth in compared to the oxide stone, and it looks dirty white in color. And the very important thing is these stones are formed, in infected urine. Infected urine, when the pH is increased to 7.2. We all know that the normal pH is acidic. But here, whenever the pH is increased and reaches more than 7.2, then only this type of stone can be formed. Okay. Then how the pH is increased? The pH is increased by the urea splitting organism. Okay. Like protease. Okay. So whenever there's whenever there's infection by these organisms, then the urea inside the urine is splitted into ammonium compound, and this ammonium compound, ammonia, causes the increase in pH. Okay, so whenever there's increase in pH, whenever the pH is more than 7.2, then it is enough to crystallize these this salt like magnesium, ammonium, and phosphate, and can form the stone. Okay. So the common organism is protease. There may be pseudomonas, providencia, klebsiella, staphylococcus, and other. The most common is protease. And see, as this stone is smooth and doesn't produce symptom that much, so it can grow slowly and slowly and slowly, and can fill the entire pelvic calyceal system. And whenever it fills the pelvic calyceal system, then it looks like the horn of deer. That's why it also known as staghorn stone. That is, when the struvite stone covers the pelvic calyceal system and forms the branching stone that looks like a horn of deer, then it is known as staghorn stone. Okay, staghorn stone. So struvite stone is the most common type of staghorn stone. Other crystal can also form staghorn stone, but struvite is the most common chemical composition of staghorn stone. See, you can form the stone. It can fill the calcium system slowly and slowly and slowly, and can form the staghorn stone. As I already told you, these are very smooth in compared to oxalate, and that can cause mm, that might not cause any symptoms for years and years. That's why it's also regarded as silent stone sometimes. And though they don't have calcium normally, still they can be seen by X-ray, but it is poorly radiopaque, not as white as other other calcium containing stones. Okay. Okay, staghorn stone. Staghorn, I've already told you what staghorn means. I know there's a multiple branching stones, then it's known as staghorn stone because it looked like the horn of deer. Okay, that's why we compare that with the horn of deer, and that's why it looked like that way. That's why we say staghorn. Basically, this is the plain X-ray QB. This is not an IBU. This is a plain X-ray QB. You can see the stone is completely occupying the calyceal system as well as the pelvis, and forming the staghorn stone. And the most common chemical composition of staghorn stone is struvite stone. Okay. And the stone is uric acid stone. Okay. This is around 5 to 10% of urinary stone. Okay. And these are multifaceted stones, not spiky as oxalate. They are common in the condition where whenever there is a excessive uric acid production in the urine, that is hyperuricosuriia, like in the case of gout, myeloproliferative disorder, or those who are treated with the malignant condition where the cell turnover is increased, and whenever there is an increased cell turnover, that leads to the breakdown of nucleic acid, and that leads to formation of uric acid. Okay. And the very crucial criteria is the pH should be less than 5.5. If the pH is more than that, these uric acid are never crystallized. This knowledge is very essential. Later on, we can apply that knowledge during our prevention part. That is, if we can make the stone urine alkaline, then the stone formation will be decreased. Okay, that's why this knowledge is important. Remember that. Okay, and one more important thing is this stone is actually radiolucent. That is, this cannot be seen by plain X-ray QB. Okay, so how to see it? I'll tell you later on. So uric acid stone is a radiolucent stone. Remember that. Okay, let us classify the stone according to the plain X-ray characteristics. Okay, that means some stone can be seen, some stone cannot be seen by the X-ray. So those stones which contain calcium, like calcium oxalate and phosphate, they are very brightly white, okay, in plain X-ray. That's why they are known as radiopaque stone. Other stone, though they don't have calcium, they can still be seen by plain X-ray, and they are not as white as calcium stone, but still they can be seen. That's why it is known as poorly radiopaque. Still can be seen in X-ray, but there are some stone which cannot be seen in our plain X-ray KUV, and these are known as radiolucent stone. Okay, and the most common cause is uric acid stone, like a xanthine stone, and the drugs that I have told you, drugs cannot be seen, like silicate, indinavir. So these are the common one. Silicate is found actually in our antacid. Okay, antacid containing silicates. If the person take more antacid, okay, due to peptic ulcer disease containing silicate, that can get precipitated in the urinary tract. Also, the patient which HIV/AIDS patient taking indinavir drug for a long time, then that can also precipitate inside the urinary system. So these drugs are precipitated if taken in long time or excess, and these stones are radiolucent stone. Radiolucent stone cannot be seen by the plain X-ray KUB. Let me show you some of the pictures. Okay, see, this is the plain X-ray KUB. I have already taught you how to count the vertebrae. So this is the sacrum. Okay, this above it is number 5. It is number 4, number 3, 2, and 1. Okay, we can go this way. You can go from above downward or below up. I prefer from below up. Okay, so so how we can describe it? There is a radiopaque shadow which is elongated. Okay, at the level of number 4th vertebra, the left side along the paravertebral region. So see, this is very clearly seen, a radiopaque shadow. So this must be a calcium stone. It's very bright radiopaque shadow. See, I have the picture here. Still, there's a radiopaque shadow which can be seen. Okay, and most probably number 5, number 4 vertebra around. So this is a elongated radiopaque shadow. Okay, here this shadow is not as bright as this shadow in the left picture. Still, it is radiopaque. So this is still a radiopaque stone, but it is poorly radiopaque. Might be strawberry stone. Okay, we have to check it later on by chemical analysis, stone analysis. Okay. See another picture. Suppose a patient, 25 years old male, complain to you that he has a pain in the back area, and the pain is radiating left back, okay, along the left flank, and the pain is radiating downwards to the scrotum on the left side. If he said that, and he also said that the pain is associated with hematuria. It's a very typical classical picture of stone disease in urinary tract, basically the ureter, because it is going downward, radiating downward. And you ordered for a plain X-ray KUB, and you found nothing. In this picture, you can just see the normal lumbar vertebrae, the ribs, the pelvic bones, the sacrum, the muscle shadow, but not any radiopaque shadow. That means the patient is not lying, because sometimes the patient might have the radiopaque stones. Okay, so whenever the clinical scenario is strongly suggesting it is a case of stone disease, but the plain X-ray is not giving you the picture of the stone, that time what to do? That time either you go for a non-contrast CT scan, or you can go for an ultrasonogram KUB. Better go for a non-contrast CT scan. Same patient, the non-contrast CT scan is now showing you the hyperdense, that is whitish structure in the upper ureter. Okay, see, patient where we cannot see anything in the plain X-ray QB, but we can see the stone in the non-contrast CT scan. That's why these type of stones are known as radiolucent stone, because they were not seen by plain X-ray QB. But these radiolucent stone can be diagnosed by non-contrast CT scan as well as ultrasonogram. Okay. So another way to classify the stone is etiology. So that is non-infectious means not associated infection. Infectious means most common infection stone is strawberry stone, that is magnesium ammonium phosphate stone. Other stones like carbonate and ammonium are also there. Genetic cause, I already told you, cystine and xanthine are purely a genetic disorder where it's very rare stone. Okay, and the drug stone, I already told you, the most common are silicate and the Indian drugs. This can also precipitate. Sometimes, if you see a vitamin C is also a drug, the excessive consumption of vitamin C can also form the stone. But this is a bit different. Okay, mainly the drug like silicate and Indian prolonged consumption can cause the precipitation. So this is the way how we can classify the stone. Okay, according to cause. Okay, so we